brain. We know we're going to have to get better at actively managing our own health, but as the report says, less than half of us are actually doing so. So how do we close the gap between the few of us who are acting on the knowledge that we need to be thinking more preventatively about our health? We've gathered a distinguished panel. Tim Kelsey will be joining us from the wings at some point, so imagine that he's there. But our lovely and excellent client lineup are Sean Hughes, who is Vice President of Design and Head of Design, Customers and Markets at Philips, which is a lot of design in one title, and Dr. Tim Chadbourne, who is the lead researcher at Behavioural Insights at Public Health England, specifically looking at behavioural science in public health and helping people make healthy living choices. I'm going to ask each of the panelists to respond to key questions, and we hope that Tim arrives in good time. Otherwise, what we might do is mix it up a bit and come back to him after we've had a few questions from the floor. But I'm going to start with you, Sean, first. Perhaps you could put some flesh on the bones of these survey findings. It's quite an interesting picture of how we consider our health here in the UK. I gave one of those headlines stats at the start, but there are a variety of revealing and quite concerning figures around attitudes and practices that we undertake around our own health that have emerged from this Picture of Health report. What did you find, and where does health tech innovation come into the picture around managing our own health and the preventative care agenda?
So I think that the report for me is a very interesting snapshot of attitudes, behaviours and even people's habits into how they think about their own healthcare. And we see from the report that there's, different cohorts have slightly different attitudes and also slightly different behaviours in how they are using data or even consciously managing their own health. So, some of the headlines are, well, the good thing is that, 80% of people realise that the nation's becoming a little less healthy, so there is interest and general view that we need to do something about it. But the other thing is we're not really active at doing anything about it per se. If you look at different groups, it was very interesting that the millennial kind of target group are very active in maybe gathering data and monitoring their own health, but they are a little bit confused. They're getting a lot of data and they're not really sure what they can do with this data. It's not really actionable for them. We have another group that is actually very confident that they're managing their health in a big way, which is maybe the 55 to 65-year-old cohort. But actually, when you ask them deeper, what are they really doing? They're saying, well, I weigh myself every day and I visit my doctor occasionally and I brush my teeth. So in terms of active engagement in managing your health, it's a little bit passive, I would say. And then even more, I think there's the really nice challenge is the perception gap between the patients and the professionals. I think the report says something like 19% of doctors believe that their patients don't have enough information to manage their own health, whereas almost the opposite. A lot of the patients think that they have all the right information to manage their health. So you've got these two people who come together in a diagnostic moment with very different opinions of their own ability to terms of helping get to a treatment. And that is another thing, is that, again, patients go to many sources, or people, let's say, people go to many sources to gather their healthcare data. And they come now to the healthcare professional expecting a dialogue. In the past, it was perhaps a little bit more patriarchal. The doctor knew best. Now the patient comes armed with all sorts of data that is very generic. And they draw perhaps sometimes the wrong conclusions. A minor ailment is suddenly a major disease, whereas actually if they maybe had a little bit more specific data for themselves based on some form of measurement over time, they might be able to have a more even and less challenging conversation. So I think what we see, from a Philips perspective, is that the challenge for us clearly is in, can we help people in the area of prevention? Because we see there's the aging demographic, we see that there's too much burden within the sort of treatment and diagnostic side of things. And if we can ease that burden through encouraging people, creating devices, programs, and also changing behaviour, we can sort of reduce a little bit the burden and the impact by keeping people out of the system where we can. And that's sort of the perspective that we'd like to take in this dialogue around healthcare.
So it's all about reducing demand. in that,
I think
in that
reducing demand, but changing behaviour. And I think the only way we can reduce demand is by changing behaviour and so getting people more engaged, and especially I think in that 55 to 65 cohort who actually are the future demand side of the equation, to get them much more engaged in monitoring their health and giving them tools to do that effectively.
Mm-hmm. I think Public Health England has widened that out to the 40 to 70-year-olds, I think, generally speaking. You're aiming at the slightly older, not. And Tim, the survey seems to have revealed a sort of classic want-should gap, you know, that will be all too familiar to you in terms of how you manage behaviour change. Why is behaviour change so difficult, and where should government be focusing their resources? I know that's a very key question for you to help meet the public health challenge.
Thank you. So forgive me for having the laptop, but there's quite a lot of content in the report, so I've tried to sort of pull out some of the references that I thought were going to be useful for the discussion. I think the nice thing is it very much sort of supports the wider understanding of the need for change. The healthcare professionals' top three were ageing population, high quality, delivering high quality services within financial constraints, and the impact of obesity, three things that we very much recognise. And I think these are all very valid points. The Public Health England has recently been involved and published sections of the Global Burden of Disease report, which you may be familiar with, which shows increasing life expectancy, increasing healthy years of life, but people are living longer with morbidity and comorbidity. So we very much recognise the issue. I think one thing that sometimes is not recognised is the good quality of care that the NHS actually delivers. I mean, there's been some recent work looking at health systems of different developed countries, the States, Canada, Australia, and actually found that Britain had ranked very highly in a number of different areas and actually produced good health services at low cost. So sometimes we don't actually sort of celebrate the strengths, I think, so that's something to bear in mind. We also need to sort of think about the impact of healthcare on health outcomes, and there's been some work which kind of suggests that only 10% of our sort of health outcomes are affected by the NHS and health systems, and actually up to like 40% might be due to behaviour, and a lot of it happens actually in the community, in the home where we live, is affected by our shopping habits and things like that. So behaviour is not something necessarily that is just delivered up, sort of health is not something that is only delivered through the healthcare system. Another thing I just wanted to mention sort of at the front was around health inequalities. And it's just important to think about how different groups of the population access healthcare, how they may access different types of support, such as as the report sort of highlights, and that can potentially actually increase health inequalities if the people who are most health literate actually take up more of those changes. So, but the key thing I think that the report, as you said, sort of highlights is this gap between what we should do and how we actually behave. This is a really key part of our work, I think, in Public Health England. Often people know about the risks of smoking, of drinking, of poor diet and insufficient activity and sedentary behaviour. So these things are well recognised, but even though we all understand the risks, we don't necessarily change our behaviour. I think a very interesting point in the report was around self-reporting, people saying that if they had physical symptoms or a doctor warned them about something, that they would prompt their lifestyle changes. I think I found that very interesting, because almost if that was true, I almost feel like we wouldn't have such a problem. I think part of the problem is that people are encouraged to change their behaviour by clinicians and don't necessarily make changes to their lifestyle despite knowing these things. So I think there's a very interesting aspect coming up from the report in terms of needing better patient education to improve poor health. People need to taking better control and responsibility and translating that into responsible actions. And I think so. There's a question there around if people are better informed, would they actually change their behaviour? and I'll come back to that in just a moment. But definitely recognised again in the report, because customers want personalised care and want data, but also recognised that also in the report that lots of information doesn't necessarily lead to better decision making. So we've got these two things that are going on that we need to kind of acknowledge, and I think that's where my call for the involvement in behavioural sciences and real understanding of behaviour change and how we all think and behave is really important. So there's a lot more detail, but just a couple of things I think in terms of behaviour change maybe that people are not familiar with. One of the models that we use is called COM-B, stands for Capability, Opportunity and Motivation, and the B for behaviour. It's quite a useful concept. It's kind of related to the means, motive and opportunity that you kind of hear about when people need to be in the criminal justice system in the States. So you need capability, opportunity and motivation if you're going to change your behaviour. And definitely information, some of these apps and wearables have a great potential to really change our behaviour, allowing us, you know, there are the behaviour change techniques that we're very well aware of from psychology, ability to sort of monitor and feedback, that kind of loop has a great lot of potential, but we need to apply it carefully, I think, as well. The behavioural insights area that I focus on with my team at Public Health England, we really have a focus on automatic motivation, which I can get into if people are interested, social opportunity. So sometimes, like in the report, they was talking about relatively few people would change their behaviour if they saw others doing it, but sometimes I think we don't acknowledge the extent to which we're influenced by social cues and also environmental cues, and I think that's worth thinking about. So there are some relatively sort of simple tools. The Behavioural Insights team, which was formerly in the Cabinet Office, came up with one called EAST, which stands for Easy, Attractive, Social and Timely. So if we think about, there's a lot of detail behind that, but if we can think about making things easy, attractive, social and timely for people, they're more likely to change their behaviour. So finally, well, a couple of final points, if I may. Just around, there's an interesting aspect of the report in terms of who's responsible for prompting individuals into action. And I think we probably all believe that it's everybody, to some extent, individual, community, employers, industry, the third sector, local, national government. It really has to be a whole system change. In terms of what the government is doing, I think there's some great examples in prevention, such as the NHS Health Check programme, which is encouraging people to come in and talk to a trained healthcare worker around their diet, around physical activity and things like that. There's making every contact count, you may be familiar with, which is really good if healthcare workers can stress the importance of prevention and talk to people about lifestyle. We do know that, for example, if someone is a smoker and goes to see a clinician, a doctor, and the doctor doesn't ask them about their smoking, they're actually less likely to quit. There's good work on doing sort of legislation and regulation around behaviour change. Smoking in cars is a recent change. Plain packaging of cigarettes you'll be familiar with. There are great work going on with my comms and marketing colleagues in terms of Stoptober campaign you may be familiar with at the moment, supporting people to stop smoking and become smoke-free. Change for Life, the One You campaign I think you mentioned, which is sort of working with the older groups. There are things like sugar swaps and smoking apps and things like this, which are all being developed. And finally, in summary, I suppose, I just advocate for the inclusion of behavioural science and behavioural scientists if we want to understand and support behaviour change. Careful about jumping into educating patients or encouraging people to take control, because we do know about this implementation action gap. Often people know what the problem is, but they don't necessarily change their behaviour. And some interventions based on training, patient education, can also be quite expensive for the amount of change in behaviour that is delivered. So I think that's, yeah, to sort of conclude, I think there's great potential, great alignment between digital and behavioural science. It's an area of priority for Public Health England, and there's, yeah, great potential, and it's going to be really exciting over the next decade, 2 decades, to actually sort of see how digital and behavioural science really come together to support people to improve their health outcomes and live healthier lives.
Thank you very much, Tim, and welcome, Tim. Thank you for joining us and doing this somewhat on the fly, bless you. But Tim, I'm going to introduce you and then dive straight in there with a question, if that's okay.
Sure.
So Tim Kelsey is the NHS National Director for Patients and Information, and specifically what we're now interested in is trying to put this into a bit of a context for the NHS, and I expect the survey findings really struck a chord for you because they were focused on healthcare practitioners as well as the general public. Your work in the NHS over the last 3 years has all been all about harnessing technology and information to empower people to take control of their health. And I imagine that's not always been easy. Where do you think we currently are in terms of potential for technology to support health creation?
Yeah, could I just step back for a second? Because I've heard some glimpses of sort of the revolutionary moment that I think we're in. And I just wanted to ask this question of people in the audience. I was recently in Korea, where they talk about happiness. And what they mean by happiness is closing the gap between healthy lived lifespan and chronological age. And it hasn't quite hit us yet, but just to bring into proportion the moment we're in as we speak in this room, what do people think the average age of death was of a Japanese person 2,000 years ago? How long did the average Japanese live 2,000 years ago? Any bids? 60? 40? 32, excellent. It's actually 14. 14. The average life expectancy of a Japanese person today is 86.6 years. Are you taking into account mortality? Well, of course not, because it's an absolute figure, so I'm not risk adjusting it. But the fact is that those are the average chronological. Pardon? From actually the Institute of Aging in Tokyo, which is embroiled in a fairly culturally political competition between Korea and itself in relation to who has the proportion of most long-lived people. But they're very close. And oh, I see. You'd have to ask the professor. I mean, it's of the Institute of Aging. But I think it's pretty accurate data. But the point I was just trying to make was that the speed with which our species is evolving isn't yet quite, I don't think, clear to many of us in this part of the world, but it's becoming very clear and economically critical to people, particularly in Asia. And on the one hand, you have that phenomenon. On the other, you have the arrival of very new kinds of machines that are capable of helping support us in the behaviour change that colleagues here have already described to improve the long-lived life, the long-lived, healthy, productive life that we should target. And here's another question for people in the room. Who here has heard of a perceptron? You have? That's brilliant. You're the first person in
There's a second
ages.
person there as well.
Oh, is there?
Gentleman there. Yeah.
Third. So the perceptron was a machine that was built in 1957 by a guy called Frank Rosenblatt, who was originally a naval engineer, which was the first machine that could learn. And of course, it was pre-digital. It was wires and sprockets, but he taught it how to learn the alphabet. And even when you degraded it by pulling out the wires from the telephonic exchange-like dashboard, it still was able to retain enough, quotes, memory to learn. So a little bit like Turing's machine, but in a different way, a machine capable of learning. And it was the first of those artificial intelligence machine learning devices which we have subsequently seen evolve into Deep Blue, Kasparov, and then today to Watson and other similar applications. And I had the extraordinary opportunity of visiting a hospital in New York quite recently where I saw for the first time an entire living organism converted into a piece of machine learning software, and really was the first time that's happened. Cell magazine published it a couple of months ago. And it seems to me that's what we should be firmly focusing on, is how can we best put data and machines capable of helping us interpret that data on ourselves, best to use to promote this productive, healthy lifespan, which I think is at the core of this report in general terms. But that's what I feel my job is at NHS England. And the NHS, we are trying very hard to make sure that we are putting in place the foundation stones for making sure that really does happen. We haven't yet hit genomics, but it's coming very rapidly, nor have we yet hit molecular diagnostics. But within the next 5 years, it will be routine, certainly for rare diseases and cancer, that we are able to, at very, very low cost, understand the molecular interactions inside ourselves. And in this way, not only produce a data set that I think will be very compelling in relation to behaviour change, but also change the nature of the medical interaction, the clinical interaction we have with our physician as well. And these are the sorts of slightly far away challenges that many health systems are not taking seriously at the moment, and as a result they are not putting in place the kind of digital basics, the real-time medical record, the apps kite marking program, the development of clinical self-confidence in the prescription of digital tools, and as a result of which not in my view capturing fast enough the importance of the data revolution that will be fundamental to this evolutionary opportunity that we have, I think, as a species. And that, look, I'm not going to go very long at all, but there are sort of three bets that we're playing in the health and care system in England. The first is transparency. So we think that we can drive the agenda of personalisation, the agenda of richer data faster if we publish all of it. Obviously, not to jeopardise anyone's confidentiality, but we are on a mission from God to publish as much data as we can. And I don't know if people have seen My NHS yet, but you can go on the web, tap in My NHS, and you'll find there comparative data on more than 36,000 organisations, including, for example, individual death rates for surgeons in different hospitals, and a variety of other similar sorts of data. So setting a real agenda around improvement through publication of data and transparency. And here's another quick question, or just an observation I'll make, which is that we launched an open data competition not long ago. Prizes were awarded at the Expo in September, and the first prize in England at least went to Cancer Research UK for putting together a little program, a little app which cuts obesity prevalence data by constituency. And much to my amazement, and I don't know if people in the room will be more learned than me on this, but the City of Durham constituency has the highest prevalence rate of overweight or obese people in this country, and that figure, the proportion of the population suffering from those in that condition, is 72.5%. Just amazing. And unless you do have a kind of transparency that enables people, clever people, entrepreneurs, others, to just cut data in different ways, you wouldn't have been able to give that MP, those local councillors, the tools to start getting real about the social challenges that they face. So I just think this is transparency is number one. Number two is participation. So properly empowering people to learn how to start taking control when they want to of their own treatment and condition. And for me, number one here is giving people access to their own data. So we've, I guess people here may or may not know that from this April, we became the first country in the world to offer all our citizens access to GP records, to online bookings, to repeat prescriptions. And over the last sort of 12 months or so, since some areas started to do this, now mandatory for all parts of the NHS, more than 6.6 million people have registered for a transactional service of that kind. I think the public is ready and willing. We just need to get ready to give them more control when they want it. And then finally, collaboration. So this is all about absolutely giving people the benefit of the kind of apps revolution, encouraging a very different relationship between a state-owned or a state-run enterprise and the rest of the community. This is all about partnership. It's about openness. The NHS is a platform for other people's innovation. So we've recently launched the first of or now more than one, sort of app stores where we are endorsing independent apps and digital tools in order to encourage self-confident use of those tools by patients and by clinical professionals as well. Just the beginnings of a journey, but it's interesting that Apple, Google, all the others are now very interested in the work we're doing here because we've sort of tried to take the initiative. I'm not going to say we're either getting it all right or will get it all right, but at least we're prepared to try and grab the future and put in place the infrastructure to deliver it. And to finish, this, of course, is not just a clinical imperative. It's not just about saving lives. And I haven't disrespected you by going through all the reasons why this is absolutely about saving lives in hospitals, because I know you'll know those reasons. But we must never lose track of the fact this is about technology. Technology is just an enabler. This is about human beings and the ability we can the opportunity we have to support them to live those better, healthier lives. And just to leave you with one example, homeless man in Hull, Ron, 53, living in a tent on a trunk road outside the city, suffering from a variety of different sicknesses, was rescued by a charity that wanted to help him get back to work, so took him into a hostel. He agreed to go, and they realised actually the reason he hadn't dealt with his health was because he'd been terrorised and intimidated by the receptionist at the GP surgery he had previously been to, and just decided he was never going to go back there, and got progressively more sick. He arrived in this hostel where they happened to be running a programme that NHS England funds called Widening Digital Participation, a programme to try and train citizens to learn how to use the internet, learn how to access NHS Choices and other health information services. And he took to it like a duck to water, and he was in seconds, having learned how to use a computer for the first time, realised that there were a number of GP practices in Hull which offered online booked appointments, where there was no need to speak to a receptionist at all, and where one of them, he discovered, would also take an email from you describing what it was you wanted to talk to them about. So he did both of those things, booked the appointment, sent the email, went into the GP practice. He had explained to them that he wasn't good with intimidating behaviour. They behaved correctly, and now he is, glad to say, a very regular consumer of that service and back to better health, and indeed now in employment. So I think at the end of the day, some of this is we mustn't forget that this is not really about digital, nor is it about data ultimately. It is about improving human beings' ability to live fulfilled and healthy lives.
Thank you. Well, that really is, we are in a transition phase to a real revolution. And it's interesting, it's beyond the health apps and health data of connected devices. And actually, you sort of outlined a much bigger picture and a more of like a sort of 30, 40-year view of where we're going in health. And I think sometimes the debate can stay at that. What are we doing with connected devices, and how is that changing our engagement with health? I'm very interested to think about this in the context of both public health and how we do change, how we actually actively change people's behaviour to become more like, I didn't hear his name properly, Ron. But also then the internal challenges within the NHS to take on this revolution or data revolution, in that I think that it may not be that the system is not taking it seriously beyond the apps, but actually there's so much potential confusion about where to make those decisions in health.
Yeah, absolutely.
So, I mean, specifically thinking, starting with the role of behavioural science in public health, how can we make healthy living a kind of choice by default? And how do we progress to this revolution where actually everyone has registered their data, that there is complete transparency, and that the apps revolution is really driving a sort of collaborative health approach? It's a big question.
Yeah, it's a big question. Asking for answers. I'm not sure if I really have a clear sort of answer. I think I just go back to the point of principle. I think we were talking a little bit earlier around the sort of behavioural science. Some of these aspects of behavioural science being a relatively new science, and some aspects of social psychology being relatively new. Much like the sort of digital developments that have happened. And I think while we don't necessarily have the answer to say we have a wealth of information like we do in the clinical disciplines, you know, a huge amount of information, and we are incrementally kind of developing our knowledge in that area. I think that it's still a young science with the behavioural science, with the sort of behavioural economics and some aspects of social psychology in terms of population behaviour change. But I think we do have some good evidence about how people behave, and some of the types of interventions that could, or some of the types of behaviour change techniques that could be included in some of these apps and digital things. So there's some good evidence. I think, I can't remember who it was looking at actually the use of behaviour change techniques in some of these apps. And I think a lot of the apps that people use regularly, there's actually not a great use of sort of behavioural science in terms of developing them. They could be much more effective at helping us change our behaviour. But there's a relatively limited use of behaviour change techniques in those things. So I think there's a lot of opportunity there. There's opportunity, I think, in terms of trying to develop things that are easier. I talked about easier social, things that are easier to use. Sometimes there's a lack of engagement, so getting people to take up these things. But then if we're talking about apps sort of specifically, they can often be used for quite a short period of time, and then people use something different. I don't know if people have heard that. I heard it a year or so ago, app snacking. I think it's a great little term that people sort of snack on. Oh, I've got a new app. Have you got the new app on so-and-so? So there's aspects of kind of engagement with apps, sort of maintenance of use of apps and continuing our use of them to change our behaviour, but also in terms of the quality of the content and how they support us. I think there's a lot of potential in all of those areas.
I think touching on those things, I think it's very interesting the insight about the guy from Durham and his rapid adoption of new technology. We were developing some programs for patients with chronic disease, and one of our concerns was if we gave some tablet devices and connected devices to sort of quite sick people, would they have the ability to deal with the technology and bring it into their life? And surprisingly, it was very rapid, the adoption. So sometimes you have this perception that certain groups of people can't embrace technology, but actually if you design it in the right way, you design the systems, and you actually engage those end users and those target groups in the development process, you can get systems and solutions that kind of have its stickiness and work with people's lives. So I think the inclusive approach and the way we develop a lot of our products and programs in Philips is with behavioural research. So part of my design team is I have behavioural science professionals in our design team, and we go into people's homes, we go out of the surgery, and we track, we monitor, and we use those insights that have been gathered from observing and working with people to inform how we then develop the solutions and systems. So I think bringing the end user in is a really critical part, and it's not just the patient. In many cases, a patient is going to have a care provider, a caregiver, or a care community that's helping them as well, and you need to understand the role that they can play and how digital technology can enable them to be connected in the care of an individual in their home or in society. So for us, the sort of user-centered approach is informing all of the technology and programs that we develop to enable people to live better and more healthy lives.
I think the gentleman didn't live in Durham. I think we talked about the good people of Durham had a obesity prevalence.
Yeah.
We always seem to end up, we will get lots of calls from Durham. But it's interesting. I mean, there were just how you actually act on that data. I mean, that's quite a compelling statistic to say 72.5% of the population in County Durham is overweight or suffers from obesity. That is a mandate to act from the public health perspective, but also to try and drive that into GP surgeries to say this is your priority issue. Is there a way that you're connecting that into your local data that you're gathering, how you then connect it into practice?
So I think maybe, again, answering that question in slightly different ways, that the question we should ask ourselves is why is it that other safety critical industries, like, say, the airlines, have very fully adopted the safety as well as economic benefits of not even new technologies, but pretty basic, rudimentary digital technologies, and the health service hasn't done so. And the behaviour change we first need to effect is that within our own staff. Of course, we need to activate patients and citizens, but the really, really big current challenge is how do we support a culture that embraces these opportunities and doesn't feel not malevolently about them, but actually for good clinical reasons concerned that they might compromise the patient's relationship in ways that won't be useful for the patient. There are lots of people I know who are avidly online banking who would be horrified if the airlines industry wasn't using the equivalent of e-prescribing in its planes, but doesn't recognise the value of those things in their own workplace. There's a really big cultural issue here which we've been doing a lot of work on. So underneath the bonnet of this talk of demand revolutions and behavioural and behavioural science for people, which is obviously vitally important, we are at the moment much more focused on supporting staff to take advantage of those things. And specifically, it's all about the really tedious re-engineering of the incentives and levers that the NHS has to promote change in behaviours. And you will have, I'm sure, all seen the 5-year forward view. And in there, we put a big emphasis on new models of care, liberating local health economies to think differently, empowered by technology to get on with it. I chair something called the National Information Board, which recently published personalised Health and Care 2020, which specifies some of those packages of support to enable these kinds of changes. But at root we've got three conundrums. One is, how do we encourage our staff to embrace the opportunity this offers them? How do we put enough money on the table to effectively, in the short term, pay for the transformation that's necessary, having had, I'm afraid, rather a poor legacy of investment in technology in the NHS? And then thirdly, how do we recognise the importance of providing capability development, not just for the internal world of NHS staff, but actually for its vendors, for its suppliers? We have a bit of a crisis, in my view, in that we are very dependent upon particularly US suppliers for much of our technology provision, when we have a very distinct values-driven health service, which in many parts is different as a customer to other health economies. So just raise those thoughts perhaps for people's consideration. But one thing I've been very focused on why I was late to the meeting now is because we are fighting a very, very tough battle to ensure that we do get appropriate levels of investment into this space in the context of the spending review. And right now that's just about the only thing I'm really focused on, because if we don't get the money, I think we're going to jeopardise our ability to keep moving forward at the pace that we are at the moment.
Okay, thank you. I'm going to open it up to the floor. We have some mics in the room and a lot of people who would like to start. So I'll start with the lady over here, and then I'll come to the middle second, but go second to, and we'll go, sorry, I'm trying to direct. We'll start here, and then we'll see where we go from there.
Yeah, thank you for that. It was really interesting, and I have no doubt that technology will improve healthcare sort of substantially. But I think the whole sort of healthcare sort of is intrinsically linked with inequality, and there's a lot of talk about apps, and I mean, and I think it's Tim who was talking about sort of behaviour. You know, if you're sort of in a relatively rich area, you can sort of go out and sort of perhaps go to a decent gym and sort of get good quality food at a price that you can afford. But if you don't have the money, you don't have those sort of capabilities. And you know, if we're talking about apps and sort of tablets and whatever, and if you can't afford those things, doesn't the sort of inequality increase rather than sort of decrease? And therefore the poor just get more unhealthier.
So how do we deal with health inequalities as they emerge, as technology becomes more prevalent? I'll take another question, then I'll come to the gentleman in the back there, and then I'll come. Well, that's I think it's on.
Yep. Oh, it's on. Sorry. James McDade from the College of Occupational Therapists. Our membership very much into preventive care. We understand that we should be doing this, and we're all for it. But I'm slightly cynical in the sense that, firstly, with smoking, for example, it took legislation to really stop the massive smoking rates, even massive decline there. Secondly, I think certain things like the health checks, you've got the Royal College of General Practitioners say they're a waste of time, they need to be redesigned. A Fit for Life, again, because business hasn't really signed up for it, it's a voluntary scheme, that has fallen down, I think, as well. And I think, for example, and it segues into data, good data. For example, the fat tax or sugar tax that's coming up on the stage. You've got Dr. Sarah Wollaston, Chair of the Health Select Committee, which has asked for the Public Health England to release a report about sugar, about how the study I think you have compiled that you've been asked to sit on by the Secretary of Health, and won't release it because of it may have problems with the upcoming childhood obesity strategy. But that is good data that can't be released for general consumption, and I think that could inform people. But what happens in those cases where the data, good data supposedly, is not being released, and you can't change behaviour? So there's a few questions within that, but I think I've covered it. So. Okay, there are quite a lot of issues within that, certainly. So if we start with the health inequalities, and you had talked about health literacy and how different groups of the population may experience health. Do you want to start with health inequalities and how to avoid them?
I mean, I kind of made the point already that, that some interventions can potentially increase health inequalities. And that's something to be very mindful of, and that we're very mindful in Public Health England. Health inequalities is a core issue for us. I think, I mean, digital has a lot of potential, I think, in this area. I mean, while you know, there are potentially sections of the population who have less uptake of digital interventions. I mean, smartphones and apps like have a massive penetration in a very short time. And the work that Tim is talking about in terms of endorsement of apps and improving the quality of things, so where people can go and they can get an app that maybe has been endorsed and can potentially really help their behaviour. I think, you know, that could really help get people access to things that work better. I think also, again, sort of some of Tim's work that is done in terms of sort of hospital performance data and making the transparency of data can have really good impact in terms of whoever accesses that hospital would get better services if the services are improved because of the transparency of the data, irrespective of whether that patient is aware of the data or not. It can work at a system level. So some of these, sometimes sort of the behaviour change may be at a different level, of an organisational level, for example, at a clinician professional level. So there's pros and cons, and I think it's just being aware and being very mindful of the potential and the issue of health inequalities.
I'd like to touch on your point as well. I mean, I don't think it's all about expensive devices, because it's about designing programs that are fit for purpose. And sometimes just maybe a text message is the way to engage, monitor and motivate with one patient. With another patient, maybe we have a program where, you know, they're using their own devices, and in another program we have a system whereby it's an employer-led program. So I think you can think about managing and motivating people's health in many different ways, and we've got lots of different pieces of technology that we can deploy together with, you know, the National Health Service and healthcare providers to create programs that work for the economics of those different situations. But yeah, you have to take into account what is it you're trying to achieve, who is the audience you're trying to address, what means do they have to either be connected or not connected, and then some relatively inexpensive ways to deliver those bigger benefits that we're trying to get, which is, you know, more healthy people staying out of the healthcare system rather than clogging the system because they're not managing their health more effectively.
Tim, you had referred to a gentleman earlier who was definitely not able to access health services or potentially health apps, etc., but you was able to integrate with the kind of new digital revolution that you were talking about. Do you have any data on health inequality?
Yeah. So there's a lot of nonsense that's talked about the way in which digital can or can't provoke inequalities in healthcare. And it is indeed true that we now have 110% coverage in this country of mobile phones, of which about 75% are smart and the rest are not smart. One of the major problems we have, which only government can deal with, and I've been going around saying this loudly, people may not realise, but I'm shortly to go to another role back in the private sector in January, so I'm allowed to say these things, is that the real problem we have is that 10.5 million people in this country don't have access to broadband because they can't afford it in the main. And of those, 50% are of working age. And this is having a terrible detrimental effect on many of those people being able to get back into the workflow they want to be part of. We also have a situation in which we have large parts of the rural estate of this country that does not have 3G coverage, which not only is a genuine threat to patient safety, we have hospitals where communications are very, very difficult between ambulance services and hospitals because the mobile phones actually can't transmit data, and I had a terrible example of that the other day in Devon. But so what we need to do, and we intend to do pretty quickly, is look at, first of all, whether or not we can switch on free Wi-Fi across the NHS estate. We have by far the largest physical imprint of any buildings, infrastructure in England, and to allow people, as many GP practices already do, some hospitals do, to surf the web in those environments. We also need to engage to enable proper 3G coverage across the country. Those things might sound rather technical, but they really are important, and only things really government can solve in relation to embedding the opportunity, at least, for people who want to engage with digital tools and services. Now, of course, that will not be everybody, but what that should do is mean that our very overstressed GPs and nursing staff and community service staff are able to therefore spend much more of their time with the people who really do not want to engage digitally, having liberated many of those that do. And amongst that client group, if I can put it like that, of the population that really do want to do digital, if they could only access broadband, are many of the most important people from the point of view of prevention and so on. So it's also wrong to think of this as a young-old thing. It's much more nuanced and complex than that. But certainly I would hope that the NHS would step up to the plate of solving this broadband as a utility problem that is currently, I think, one of the biggest obstacles to opening, liberating people, being able to make the most of these digital services.
And if we pause on that question around how legislation can stop some of these things, when referring to the Sarah Willison report now, we wouldn't take that specific item to discuss right now.
We want to hear about that.
But what happened, how do you use your evidence base to influence legislation, and legislation does, make for change?
Sure. Maybe I should. I'm not going to. Basically, there are hearings underway in Parliament, and Public Health England submitted evidence to the Secretary of State already, and I think that discussion is happening. So I don't think it's my place to sort of really talk about that. It'll be coming out through other forum. In terms of regulation, I think it's a really interesting question, and again, I'm not sure if you're familiar with the Nuffield Council ladder of bioethics. I think people sort of look to the regulation aspect of the interventions in smoking as being the only thing that was effective, but actually it was a lot of things across that ladder of bioethics. For people who don't know, we're talking about sort of doing nothing at the bottom to patient information, going up through enabling choice, changing the level of incentives to kind of regulation and legislation. So at the bottom you kind of get the easiest things to do, but potentially the least effective things to do, and as you move up you kind of get more controversial and potentially more effective in a way. So I don't think it's a question of one or the other. I think the biggest changes in public health probably happen through a more combined effect, where we work through regulation where that's appropriate, and through other sort of levels of change as well. But my sort of my request was that we kind of use behavioural science in all of those areas. So if we're developing regulation, if we're developing other interventions at different levels, we think about how people are going to react. And I think that's we think about how people actually behave rather than how they say they behave. And I think that way we will get greater effectiveness of everything we do. So I think it's a combined effort.
So let's try and get 3 more questions from the audience. I said I would start in the middle, and then lady in the mustard, and the gentleman in the nice coat thing. So if we start with that lady there, and then we'll come to you.
Thank you. I've not heard anything at all about mental health. I've heard about smoking, obesity, homelessness, but I'd like the panel to comment on how this is going to help with mental health.
Okay, thank you. The lady in the mustard. Oh, have you got a microphone? Yeah.
Is it on? Yeah. First of all, I should say how brilliant the NHS has been at several very crucial points in my life, but also very crucially to actually make me a healthy person has been the osteopaths I've been to, the acupuncturists I've been to, and their way of their approach is how to keep their patient healthy, as opposed to the doctors, the GPs are the troubleshooters, and at best you're suggesting they can be proactive troubleshooters. But I think, we are facing a crisis, it's really well acknowledged. I think a much more radical approach is needed, and I think responsibility has got to change somehow. I don't know how, behavioural change and so on. I think you're tinkering at the edges with apps, but I don't know. I don't have an answer, I'm sorry, but I wish there were one. I hope there will be.
Okay, gentleman.
Justin Mullins, New Scientist. I'm interested in a paradox that's right at the heart of this debate, which is that people may know what they need to do, but then they don't do it. So it doesn't really matter what information you give them. And I want to sort of tease this apart a little bit more, because people do make change all the time. So what's the difference between people who know what they should do and don't do it, and the people who know what they should do and do it? And how does behavioural science find out about this? If we don't know what that difference is, how are we going to find out?
Okay. I think we could just... Oh, he's gone. All right, we'll start and I'll come back to you next. You'll get that last question, even if it's the last thing I do. Okay, mental health. Who would like to comment on where's mental health in this?
Looking at me.
Well, at
yeah,
the
I'm not
Tims in
sure.
general.
I don't know if you want to. I don't know a huge amount about mental health. It's not where my background is, but I know PhE mental health is very much a core aspect of and a sort of priority area for across all of our different areas. So whether it's smoking or obesity or whatever, aspects of mental health cut across all of those as well. And the difference between sort of mental ill health and mental health as well, maintaining people is, I'm looking at the wrong person.
Yeah.
In terms of maintaining people in a healthy state, and so health and well-being, I think the focus on well-being and keeping people in a healthy mental state has kind of jumped up the ranks in terms of priorities.
Yeah.
The
Yeah,
parity
so
of esteem.
So first of all, just to say that you'll be familiar with all the various national programmes that have been started over the last 2 or 3 years in relation to mental health. You're absolutely right. Parity of esteem is a massive problem. There is, historically, mental health has not been given anything like the weight of seriousness that it properly deserves, particularly, actually, I would say, in children and young people. We know, again, I won't rehearse all the statistics, we know its impact. We know that physical health and mental health are very closely aligned in the same individual, that we can't just treat one symptom without the other. We have an extremely poor record in provision of clinical therapeutic services, particularly in the community, for a variety of mental health conditions, but notably, I would say, for drug and alcohol abuse. So all I can say is we haven't done nearly well enough in the health service, in my view, collectively. Martin McShane leads on this with other colleagues, Geraldine Strathdy, and what they have, I think, successfully done in the last 3 years is put this squarely on the map in relation to priorities. It is the first time in the history of the health service that last year the business plan of anything, I know this sounds ridiculous, administrative, actually prioritised mental health, but it's just, these are small things which build into a momentum that becomes unstoppable. I've been particularly involved around IAPT, so I think the IAPT story has been a successful one. For those who don't know what that is, this is about improving access to psychological therapies, to talking therapies. We know anyone who's had mild to moderate mental illness, and I'm sure there'll be a number of people in the room who have had it or are having it, will be aware that getting access to cognitive behavioural therapy is extremely difficult, and the NHS is underserved in relation to that service. But we have managed, I think, with the evidence suggests that we've managed to very rapidly increase the level of access people are able to get to IAP therapies, and that's not just because we received a large amount of money from the government to incentivise those services to be deployed, but also it is partly about digital and other means of access. So for some people, there are very proven digital services which do help provide, for example, work through cognitive behavioural therapy treatments, and indeed even in psychosis, there's a good literature for digital services providing support for people at home. There's a lot of mental health, as you can understand, there's a lot of emphasis placed on anonymity in relation to treatment, and some of these digital services help with that and help provide more self-confidence amongst patients with those sorts of things. But I would just say we've got a long way to go. I do, however, think that we are beginning to make progress. I am very personally concerned about the the continued lack of infrastructure outside of psychological therapies, particularly in relation to acute services. And obviously, a very big related priority has been to resolve treatment, home-based care for people with learning disabilities, which isn't necessarily the same thing, but often overlaps. So I think there's a big journey, and I'm sorry we didn't mention it because it is fundamental to a sustainable health service.
I just mentioned briefly the fact that public health is now obviously the remit of local government, and I think local government really do put sort of well-being as a priority in many areas, well-being as a priority, and I think there's a great focus in many areas in terms of well-being and mental health from local government.
Maybe just to answer both questions, one a little bit thinking more broadly about care as a continuum, and the other one which was about how do you invoke behaviour change. Well, we're doing research to try and find, there are sort of what we call might be behavioural phenotypes, and different types of people respond differently to different types of information. So if you can identify the sort of response of an individual and what will motivate them to change, you can then tailor your program of information to fit that phenotype. Now, some people need an awful lot of data and they want to have endless bullet points about facts, figures, and it will drive them to change. Other people just need to have a very compelling burning ship and they will make the change. So I think one of the challenges we have is understanding the end user, the person, in a broad sense, and then being able to coach and motivate them in a way that really is fit for their phenotype will help us to provoke change. But another thing that we've done very simply, and it's maybe changing tack completely, is that, for example, we know that people like to eat French fries, right? They like to eat chips, but they're inherently unhealthy. So rather than stop people eating chips, we developed a way that people can have the benefit and enjoy French fries. We have a beautiful product called an air fryer, which actually allows you to cook chips in a much more healthy way. So you get the benefits of what you like to indulge in, but at the same time you get you have a more healthy way of doing it. And I think as a technology company we can think in smart ways, because you can't always change people's behaviour, but we can help them with tools and technology to get some enjoyment as well. So.
Can I make a quick but important point on that point? There's a kind of debate and there's an interaction between trait and state, which is kind of what you're talking about, the traits that are sort of inherent in people and how they might react consistently versus the state in terms of if you're in a situation, how you actually react. And I think what is becoming much more apparent is about people change, and people react differently in different situations. People are not necessarily consistent in their decision making. And that importance of, as I was talking about it earlier, the social cues and the environmental cues and how we make decisions in the moment is actually really under-acknowledged.
So Tim, do you want to also respond as we close? I fear that I may have to ask you to ask that question downstairs because we are overrunning on time. But do you want to think about that paradox at the heart of the debate? People know what they want to do, but don't act.
Yeah, there's a very good literature on this, which I don't know if have you seen David Halpin's new book? So the guy who set up the Behavioural Insights team has just written a book essentially relating a lot of the evidence of why behavioural science does absolutely have a place alongside other evidence-based strategies for health intervention. And I think we're now at the point where we've started to really figure out which ones do and don't work. So and that, obviously, as was just said, it's a very personalised experience for the individual, but we can start to see how certain things do scale. And I think you're going to see some very evidence-based initiatives in the NHS around promotion of sort of multi-platform disciplinary services which will support people in very personalised ways to get a grip on their healthcare. And just to make the point that digital is only one part of that arrangement. So I think what we're beginning to definitely see is that coaching and mentoring is probably more important than access to digital services, though most people do want to have the option on that as well. So combined service offerings, which people can access in their homes, seems, pretty common sense would tell you this works, but actually the evidence really is quite compelling. So I think we're at the point now where it's not just Fitbits, which are gimmicky, but we are getting to the point where evidence-based packages of intervention involving a variety of different approaches really do move the dial for quite large populations of health service users.
So I'm hoping that responded to the question about what does radical responsibility for prevention look like as well. So I'm going to have to hide my Fitbit as it's a bit gimmicky, and say I'm sorry we've run out of time. So I'm sorry.
We can give you a new personal health watch.
Oh, how fabulous! I will look forward to that. If we didn't get time to take your question, fear not. Thanks to the generous support of our partners Philips, we continue the discussion downstairs in the Benjamin Franklin room over a glass of wine. Although please keep it to moderation. You'll find details of this report in reception and can find links to it via the RSA website. Do keep an eye on our website. We are doing considerably more work in the area of health and social care, and we're keen to find out if you are an RSA fellow, if you are working or interested in this area, if you want to get involved, do sign up to our mailing list so that you can stay in touch with our team, our research team. But finally, please join me in thanking all of our terrific speakers for an excellent session. Tim Chadbourne, Tim Kelsey and Sean Hughes. Thank you.